A truly fit-for-purpose electronic medical record would be set up from the beginning to close the gaps between in-hospital, out-of-hospital and non-clinical care, and that for the best outcomes and health and well-being of the patient, no matter what the diagnosis, with a bonus that will save a lot of money and workforce stress.
Hello and welcome to Pulse Amplify, where we sit down with the leaders and changemakers shaping the future of health. Proudly brought to you by Pulse IT News. I'm your host, Louise Shaper.
And I'm your other host, George Margellis.
Across the world, there's growing recognition that health isn't just about what happens inside a hospital or a health service. It's also shaped by what happens in our communities, our relationships, and our environment. Social prescribing is one of the most promising shifts in healthcare right now, a move to connect patients to non-clinical supports like exercise, nature, art, or social connection, but making it part of mainstream care. Now, while the promise is clear, the practical challenge remains. How do clinicians, community services and digital platforms come together so that a social prescription is as easy to write and track as a prescription for a pill? Well, joining us today are the three authors of a recent article which calls to integrate social prescribing into health reforms. Today in the studio, we're joined by Professor Peter Brooks, a clinician academic with decades of experience in medicine, workforce, policy and health systems. Dr. Claire Smith, retired GP and advocate for integrating social and environmental determinants into primary care. And last but not least, Dr. Frank Nicklason, a geriatrician in the Tasmanian Health Service, interested in social and environmental determinants of well-being. Today, they're going to help us explore what social prescribing is, why health systems around the world are paying attention, and, especially for our digital health audience, how technology, data, and interoperability can bring this vision into practice. Peter, Claire, and Frank, it is so great to have you in the studio. Welcome to Pulse Amplify.
Thank you.
Thanks for having us.
All right, Claire, I want to start with you. Now, for our listeners who are unfamiliar with social prescribing, can you describe what are we talking about here and how is it different from mainstream prescribing?
So social prescribing is when you recognise the importance of all the really well-known social determinants of health. These are the circumstances in which people are born, grow up, live, age, as well as the health services that there are. But they're also shaped by income, education, occupation, gender, ethnicity, and many other factors. And then on top of that, there are individual circumstances and things like being bullied or domestic violence, homelessness, being really stressed by the state of the environment. All of these things have impacts on health. And actually, some of the best evidence for improving people's health is in preventive activities in these areas. So what we need is to cross that gap between, first of all, in-hospital care and out-hospital care, but then between medical care and non-clinical care, because really we need to address all of those, bearing in mind, as you said in your introduction, actually the things that predict the best quality of life, including whatever illnesses are wrong with you, are exercise, social connectedness, good nutrition, and being in nature. And they're not specifically clinical activities, and yet they have a huge bearing on clinical outcomes.
So I understand in other countries like the UK, Canada, New Zealand, they've all got national commitments to social prescribing. How can we learn from other countries' models of social prescribing?
Well, a lot of other countries are moving forward with this, United Kingdom, Canada, New Zealand, but also Australia. Claire mentioned in our article program that's in Gippsland, the Kaleidoscope program that's been adopted in general practice. So the research from the UK is very interesting. It shows that general practitioners keen to adopt social prescribing, that they can reach a lot of their patients and it improves their well-being. And the general practitioners themselves report that it reduces the time that they need to spend with a person trying to solve social issues. So it's well received by both doctors and their patients, and it really facilitates very useful connections. A lot of our patients that are older really have difficulties with social isolation, loneliness, and a lot of factors that make it difficult for them to engage in those vitally important activities, whether they are just social or social plus exercise or both together. So there is a lot already happening, a lot more could happen, and there is a substantial benefit for people when they do engage in these activities and connections.
And at a practical level, so I walk into my GP or my geriatrician, and instead of actually writing maybe a prescription for a pill, I might get a prescription for yoga class or something. Is that too simplistic?
We've got to make this a very easy, almost like a default position, that rather than writing a prescription for an antidepressant or an anti-anxiety medication, that whenever we think that that might be the way we would go, that there might be a better way. It does work best if there is a linked person. So a yoga class may be just the right thing for you, Louise, but it's really trying to match the intervention with the person who's in front of you, linked person who knows what's available in the community, and a lateral thinker, and someone who is very focused on a highly individualised approach to link that person with what would likely be the best activity for them, and to encourage them to stick with it, because it may not be on the first instance that the match is made.
And Claire?
So in some places there's a link person, and that would be great. But as we're talking about the rolling out of the electronic medical record and trying to close this gap, and with the advances of AI, and some of the existing programming that we've already got, for example, in health pathways, where GPs can already very quickly and efficiently look up and see the referral pathways for all kinds of things, that, for example, there could be a loneliness pathway and it could be localised. So you could look down, you could tell it, I live in Kingston, I've got an elderly lady who's a bit disabled, who would like to meet some people, and it would be great for her to get some exercise. And then it would tell me, oh, Kingston, there's a program called A Dose of Nature. Every Thursday morning, some people meet at 9:30 at a spot that you can easily find out about, and somebody will be there. It could be a GP, it'll definitely be a council worker, but they'll be supported by a yoga teacher or a bird watcher or somebody else, and you'll have a social experience. You'll meet some people, you'll do a little bit of exercise, and that ticks a lot of those boxes, and it's actually happening and it's actually working. It's finding those programs and linking to the patient. And that's where I think really clever technology and digital assets can help us. And this is a lot about shifting the emphasis from focusing on the hospital system to focusing on the patient.
You made a great point there, Claire, that there's technology available for connecting other parts of the healthcare system. You guys are going through a bit of a transformation down there in Tasmania, where they're implementing a new system which includes community care. How do you see this new digital transformation journey? How can you leverage that in the short term to get social prescribing as part of the norm?
I'd like to see it really clearly embedded from the very beginning, so that it's there as part of the offerings as it's rolled out and people are trained in it, not just as an add-on, but as a really important part of the patient journey. Because just take loneliness. You can't just say stop being lonely. It doesn't work. If people knew how to fix these things, they'd fix them. But they don't. So there needs to be an introduction. And talked about writing prescriptions. Before I retired, I was literally writing on a prescription pad a customised prescription for going to a park. We'd look on Google Maps, we'd choose a park, we'd choose whether they could get there, how long they'd spend. So that's a very, very simple example. But to build on that, that's how the Dose of Nature program came up. Something where you can make connections. In the Dose of Nature, someone who started come along had a hip replacement. She was new to the area. Other people in the group started bringing her meals, checking on her. To me, that is a totally successful program. And if you could have referral links so that the people that need that and can actually access them, that's a total winner. And then I'd also like to know what to do with this really upset, angry 16-year-old who's so distressed because he thinks by the time he's grown up and become a marine scientist, there won't be any reefs left for him to dive on. That's real. That's last week. How are we going to connect that young person to a group of other young people? Because we know that taking action is the best answer for this environmental distress, but you can't do it by yourself. We know it's action with others. So there'll be some other young kids of his age in the area. How do we find those programs, link them, register them, make sure that they're of reasonable quality, because we've got to put some safeguards around it. But that's all possible if we really understood how important it is and how many gains we make for the entire health system, for that young person's developing life and health, that old person's ageing experience, There's a lot to be done, but it's possible if we kept bringing that patient back into the centre of our focus.
Peter, what is your take on how this could be integrated into the Blue Gum program that's happening in Tasmania right now and making social prescribing part of that from day one, as Claire said?
Firstly, EPIC, which is the one that's chosen in Tasmania, they already have modules. EPIC actually has models for social prescribing. There are 3 or 4 specific modules which are called, I think, community health and welfare. And it means that you've got to invest in those modules, but it's not like you've got to introduce or create a whole new system. It's actually there.
Unfortunately, as we know, our healthcare system is so fragmented. So how do we bring in some of those other services? I mean, we have social services, we have age services, we have NDIS services. The EMR is an opportunity to do that. The software can help get us together, but it requires everyone to have access to the system. Here in New South Wales, we're doing a big rollout, which has totally ignored community medicine. So it's just a big system in hospitals and forget everything else. So hopefully Tasmania and our good friend John Lambert will do a better job there, I hope.
I'll set you onto him if he doesn't.
Yes, please do. We'll keep on him on that.
So, Peter, what evidence are we seeing in terms of patient outcomes, cost savings, or health system benefits? What does the literature tell us? Where does it work?
Well, we've known about social prescribing for a long time, since the 1960s, really, with the Marmont studies in the UK, who actually was an Australian.
Oh, so social prescribing started in Australia or with an Australian?
No, Michael Marmont was an Australian public health physician. He went to the UK and he did this incredible study on the British civil service with about 15,000 people, and showed basically that if you were head of the service, you lived for 100 years. If you were the minor clerk, you lived for about 60. And if you were the dustman, you lived for 40. And that sort of started off this whole issue about social determinants. And so there's growing evidence that social prescribing can lead to very significant reductions in avoidable GP appointments, in hospital admissions, all of that sort of thing. And it's relatively easy to do, and it's relatively cheap because a lot of the stuff is already out there. But the long-term studies are really not there because things are really just starting off. There's really good evidence with depression. Mental health is really interesting because it makes a big difference, and it doesn't seem to matter what sort of underlying mental disease you have. You are still likely to respond to the social prescribing you are getting.
Okay, time for a quick break, but in a moment we will be back with more, including how AI can assist with social prescribing and what's required for EMR utilisation to make social prescribing really pop. Don't go anywhere.
So I guess the challenge is knowing what services are out there, and obviously, stronger governance around them. Because as Claire pointed out, you need to make sure that person you're sending them to or the group you're sending them to is valid and is safe.
A lot of this stuff is actually already out there. And where you go is to the municipality. You go to the local council and see what things they're running. Are they running Scottish dancing? Today, is there a walking group? All of that sort of stuff.
I think it is really important that there is these other approaches, other entrees to social prescribing. And a lot of it is held in the local government areas and other services.
Short of being able to roll out individual link people, which would be a fantastic model, we could employ a few people just to keep those contacts up and make that interaction between the medical record side and what's going on in the community available, so that, as Frank said, we can actually facilitate that link quite quickly and easily. It's really just got to be about making it really quick and easy for the GP or anyone in the health service to access those out of health system services and then facilitate the patient making that crossing. Someone who was putting those up on a medical community notice board so that doctors could go and have a look on the medical community notice board, like you can at a cafe, in their surgery quickly, and they could say to AI, look, the patient I'm looking for is a 45-year-old woman who cares for children or doesn't have her own transport, so it's got to be accessible by bus or walking. Then the AI can sort it out because it's good at that and say, well, these are the 3 things that could be offered. And then it's in the record. And then ideally, the doctor would have as much investment in how the person went as their blood sugar levels and what's their blood pressure reading, because they're all just as important, possibly even more.
You have to think of this in combination with the workforce. Britain, for example, and Australia now are just developing what we call patient navigators. In the UK, they call these people link workers. The NHS actually pays for a full-time health navigator or link worker for every 13,000 patients that you have in your practice. That link worker can check to see that you've actually turned up at the Scottish dancing or whatever and are actually getting some use out of it. In Victoria, we actually developed with one of the universities a TAFE project for training navigators, and that's up and running. So there are a whole bunch of other ways that we can actually help patients because, we've created health systems which are so complex. I can't understand them, let alone the patients. So it's not surprising that we're in trouble.
So we've often spoken on our podcast about new roles in healthcare, and this is obviously an example of that, and also new business models, because the current business model of fee-for-service, the 15 minutes in and out type general practice has its challenges. When we look at how we can integrate these sort of systems into general practice, what are the policy levers we can use with the department to demonstrate that by investing in link workers or access to this community notice board of services, there'll be other savings in the system? Because whenever you speak to someone in the Department of Health, it's all about saving costs or decreasing risk.
There's some pretty good evidence of cost savings, both in admissions to the hospital. These studies need to be long-term and they need to be probably a little larger than the ones we've got at the moment. But there's enough data out there to be able to persuade health departments to get in and do something.
Peter also touched on another really important point, which is the stress load on the doctors with so many demands. In general practice, it's bonkers, taking time to look at maps to try and find a park. That is not a really good use of my level of skill, but it's something I find myself drawn to do because I can see that's going to really benefit this patient. The places where some of these things have been rolled out, like in Gippsland, there's good evidence that the doctors have really enjoyed it because they're attending to that, but it's not taking them half their consultation. So they find a way to address that along with the blood sugar and the blood pressure and the kidney function. When did they have their vaccination and so on? We do need to add it, but we need to add it in a way that's manageable and that is supported by our electronic medical record as it's rolled out.
Yeah, this is a very exciting prospect. Claire, as a GP, do you find that with the authority that naturally comes when a clinician says, hey, this is what I prescribe for you, does it really make a difference? And I see both Frank and you nodding.
It absolutely makes a difference. I think one of the things that doctors are good at is being salespeople. I can sell a colonoscopy, so I should be able to sell a walk in the park. So I think that my enthusiasm I think this will really benefit you, your health and your quality of life and just how much you enjoy the day if you could just find the resources to get yourself to this park or this group or this book club or this library event. And I'd love to hear how you got on. There's a whole lot of a bigger chance of doing that. Even really difficult things like giving up cigarette smoking are significantly improved by the GP saying, I'd love to see you give up. Please try again. You only got this far. Good luck next time. You'll get further. Our enthusiasm and commitment to those outcomes is a really potent and powerful tool, and we should be using it in all these preventive activities because the return, if we just want to talk about business models, the return for prevention, it's so good. It's like $1 here saves 10. I don't know what the numbers are there, but they're huge. And yet we spend a trifling few percent of our total health budget on prevention. And this is a way for really cheaply adding more prevention. Seems like a no-brainer to me.
It's really easy to link deficit in social activity or connection with the health problem that a person's having. A lot of my patients have Parkinson's disease. One of the things that's critically important for people with Parkinson's disease is that they need to build exercise into every day. But they also need social connection. They need to be meeting people, having conversations, having their confidence and sense of optimism and well-being boosted by nice conversations with people. And that's exactly what happens. It's really quite remarkable that people will do that if you spend just that bit more time, as Claire said, to make that link between the issues that are relevant for an individual and what they stand to benefit and what they actually do benefit when they undertake those activities.
One of the things I'm really keen about is that when we start to develop these things, we do co-production, co-development with the people who are going to use them, our patients. We never do that. Do it with the patients because they can tell you things which will improve it so that your uptake is going to go up. There's a wonderful paper which was a comparison of social prescribing across 12 high-income countries. A whole range of activities that were being done. You know, they're very different. Some they've got private sector involved, some they've got philanthropists in terms of funding. Some really interesting models, and they're all there for people to say, look, we could try that one. It seems to work. It might be able to work in our sector.
We've discussed a number of times in our podcast the idea of participatory medicine where the patient and the clinician work together and co-design. What sort of training do we need to have at an early stage? Because I reflect back on my training, and my son recently graduated from medicine and discussions with him. Social determinants is covered in one public health lecture, probably in year 2, and that's it. You know, it's never brought up again unless you actually go down the public health path. How do we get the young clinicians who are coming into the fray to think beyond what is the latest drug or what is the latest procedure, but think about going back to nature, going back to the sort of things that even probably Hippocrates recommended?
I think one of the problems we have is the increasing specialisation and subspecialisation of medicine. So everybody's looking down a straw to see what they can see at the end of the straw, some tiny little part of the body which is behaving. And I think that's a real loss for us as a medical profession and as a health service, because people aren't made up of little tiny dots, and it's joining those dots and closing those gaps. I'm sorry to hear that somebody got through their medical training with so little attention to the social determinants of health, because in the medical student tutoring that I've done, it's actually embedded in their history taking and in their reporting. But I think if we could just encourage all our clinicians to broaden their view a little bit and remember that this, whatever they're looking at down their little cardiology straw or whichever one it is, actually belongs to a whole patient. And the GP is the one who's kind of stuck with it all, because everyone says, I can't do any more for you, back to your GP. And I would love to see more emphasis and more training. And as this EMR is rolled out, in that training, see how much it can do and see how much that will benefit your patient and you, because life will be easier for you as the clinician, especially for the generalist clinician, to know that many of these things, as many as possible, are being addressed. You know, no one wins anything by just focusing on one little problem area. The problem areas are huge and complicated. All those social determinants, they're endless. And so we can't take the whole thing on, but we can do as much as we can. We have to avoid that. I'm only going to deal with the problem that you brought in. We're just going to deal with the one thing that you said was your issue for the day, because that's better business. Like, it might be better business, but it's not better healthcare.
Really well said. Okay, so final question, guys. If you could all send one message to a health system leader, and I know a lot of them do listen to this podcast, what would it be? Claire, we'll start with you.
So I think a truly fit-for-purpose electronic medical record would be set up from the beginning to close the gaps between in-hospital, out-of-hospital and non-clinical care, and that for the best outcomes and health and well-being of the patient, no matter what the diagnosis, with a bonus that will save a lot of money and workforce stress. That was a bit of a long sentence, but you know.
No, that was a great sentence. Fantastic. Thanks, Claire. Peter, what's your final pitch?
Okay. I think there's enough positive evidence now for social prescribing to start major collaborative trials exploring long-term therapy and impact on communities. So if you're interested, link up with groups with experience in this area. There are a whole bunch of groups, including the Australian Institute for Social Prescribing, and co-develop with the communities some interventions and get on with it. Enjoy it.
Thanks, Peter. And I'll put a link to those resources that you guys have pulled together as well, so people can download them from the show notes. And Frank?
We need to get the message out. We need to celebrate the individual triumphs of social prescribing, the benefits that people have had, make those wins really accessible to people so they can understand better how this can be far more powerful than those tablets that we prescribe so often for depression and anxiety and for type 2 diabetes, when there is a much better way, closer to the root cause of the problems for attending to those issues.
Nice. It's all about a focus on the patient, isn't it? Thank you all so much. I'm amazed that we've managed to find time in 5 people's diaries that aligned at relatively short notice too. So thank you all for joining us today in the studio. It's been great having you on the show, and we look forward to our listeners finding out more about social prescribing. And I'm sure there'll be multiple people who will send this episode on to our friend John Lambert as well.
Yeah, no, I have to agree with Louise. It's very heartening having passionate clinicians who looking at solutions that go beyond the latest drug or the latest procedure, the latest research. So I look forward to seeing this being successful in Tasmania and then getting rolled out across the rest of the country.
Thank you, Louise and George. It's great.
Yeah, thanks so much for the opportunity.
Thank you.
Thank you for listening to Pulse, brought to you by Pulse IT News. Pulse is produced by Ivan Jurek of Octopod Productions. Thanks to Emily Mara, co-founder and publisher of Pulse IT News, for her support. And look, just a big thanks to everyone for listening. Please make sure you subscribe, follow and rate us wherever you get your podcasts. And don't forget, you can visit pulseit.news to sign up for the e-newsletter and explore Pulse IT's massive, and I mean massive, digital archive. Send any feedback or topic suggestions to pulsepod@pulseitnews. We always love to hear from you.